Okay, well, we're going to get started. So, good morning, everyone. Happy Mother's Day weekend to all the mothers. We want to welcome you to Trio Maryland's May Zoom meeting. I'm Marty Marin, and this is my wife, Michelle, and we manage Trio Maryland. We'd like to welcome all our members and guests this morning, and thank you for attending. Today's topic is all about the transplant recipients and skin cancer. You will learn all the fun facts here this morning. Don't worry, because in June we will have June off because we will be preparing to go to the Transplant Games of America in Denver. So we will see you in July.
Hey, good morning. Good seeing everybody. We're really lucky today. Today's guest speaker is Dr. Jennifer Powers. She's new to Baltimore, so please welcome her. And she leads the transplant clinic at Johns Hopkins Dermatology. Jennifer Powers hails from Illinois and has been a board certified dermatologist and Mohs surgeon since 2012. She previously worked at Vanderbilt, Duke, and the University of Iowa. She has had the privilege of taking care of transplant patients with skin cancer in many places across the United States. Dr. Powers has received grant funding from the Department of Defense to study melanoma in the military. She does research on scars and is a member of ITSCC, International Transplant Skin Cancer Collaborative, where she works with others around the country to improve dermatology care in transplant population. Sorry about my stumbling. Dr. Powers is a mother of three whose husband coincidentally is also in medicine, and he also works at Johns Hopkins Hospital. We're really fortunate to have Dr. Powers here address our Trio Maryland community. Thank you for presenting to our group. Welcome, and we now turn the program over to you.
Thank you all so much. It's great to meet many of you. And, I know this trio group has a long-standing history of a very strong presence in the area. I'm fortunate to be friends with some of the others who have run this transplant clinic before. Perhaps many of you worked with Kristen Bybee and Manisha Loss, who really started and put this program on the map. And I will also just add that, my interest in dermatology and skin cancer really started with transplant patients because when I was a medical student at Vanderbilt, some of the first patients that I saw and that we studied in the laboratory were patients with squamous cells in the presence of heart transplants. And so, as I reflect on kind of my journey through dermatology, I'm really delighted to share with you that this is really where my journey began. And like they said, I've been very privileged to take care of many patients with skin cancer and other skin disorders in the setting of organ transplantation. So I'm hoping today to provide you all with some good information, not only about your immune system and the medications that you may be on, but also skin infections and skin cancers that you want to have on your radar. I think it's also helpful for us to talk about some practical strategies that you may be able to employ in your day-to-day life. So without further ado, we'll take a minute to think here about the immune system and how it keeps you healthy, because our immune systems are so important in day-to-day life, helping us do a number of things. I think as kids, we all know early on in life that our immune system fights germs, so bacteria, viruses, and fungi. But a lot of us forget that one of the main things that our immune system does is actually cancer surveillance. And so anything that impacts the immune system raises the risk for cancers of various types. And of course, here today we're talking about skin cancer, but there are a number of different things that can show up. And so our immune system really does, play a significant role in keeping us healthy. But really, to have a healthy immune system, it needs to be in balance. And in the setting of, an immune system that's altered, there really is a change in the relationship between the immune system and what's happening with germs, harmful substances, and cancer cells. So after transplantation, we know that one of the important things is that the immune system isn't too strong, because if you are getting a foreign kidney or liver or pancreas or heart, that new organ in your body really has to be accepted in some way. There has to be something that we call immune system tolerance, where your body recognizes something that is foreign but does not go attacking it. And so there is a new way to establish balance and what we call homeostasis between your body and self and this organ that was graciously donated by another human. And there are medications that help reset that balance, creating harmony between your body and the new organ. So because of that, we know that those medications may lead to an increase in certain bacteria, viruses, parasites, or fungi. We may see more cancer cells developing, and that then can lead to some of the pathology that we see in the clinic. Before we actually jump into some photos to actually look at that, I want to talk a bit about the immunosuppressive medications that you may be on to help keep your transplant healthy. So we know that, for example, prednisone is one of the main medications that is employed early on in transplantation and then continued throughout the transplant. I would say most of my transplant patients who are getting skin exams are on at least 5 milligrams of prednisone. And while it isn't the medication that we often think of most commonly, I would say this is a medication that we see all the time in the skin clinic. In fact, we often prescribe it. So we're even more familiar with the side effects that you may see in the skin because of the prednisone. You've probably heard many of these, since prednisone and its cousins have been around since the 1950s. But stretch marks or striae, bruising or what we call purpura because the blood vessel walls become thin, steroid acne, and Cushing syndrome are some of the few side effects that you may see from being on long-term prednisone. And because of that, it's very important that you don't overdo additional steroids. So the topical steroids, in addition to steroids by mouth, can actually lead to an acceleration of some of these features. And when the skin becomes thin because of the prednisone, it can also make healing from surgeries a little harder. So not that these things aren't manageable, they really are, but some of your other doctors may not be aware of this. And so when you are armed with this information, you can be the advocate who understands what's going on. What about tacrolimus? Tacrolimus is something we call a calcineurin inhibitor. And tacrolimus really, in a lot of ways, changed transplantation medicine. Because with just prednisone, unfortunately, that was often leading to a lot of systemic side effects that were not great in the long term. 5 milligrams, not a big deal, but to be on 20, 40, 60 milligrams of prednisone is a big deal. And so enter tacrolimus. Tacrolimus really put transplantation on the map and made it much more feasible. However, tacrolimus is also what is responsible for a number of side effects on the skin, including skin cancer and things like alopecia. The alopecia in this photo, meaning hair loss, happened after a simultaneous kidney pancreas transplant. Fortunately, in dermatology, we have a lot of tricks up our sleeve. And so, after using topical minoxidil, this patient saw a lot of improvement in their hair thinning. Minoxidil is also known in the business as Rogaine, and these days we even have minoxidil that is given by mouth. So, minoxidil happens to be a blood pressure medication that, when taken in really low doses, just grows the hair like crazy. And we're not just using this pill in transplant patients, we give this to a lot of people. In fact, lots of dermatologists even take it. Usually it's a pill that we give 1.25 milligrams to start, and it really does promote great hair growth. Side effects really are mostly limited to a little extra hair growth everywhere, but most patients are so delighted to have more hair on their head that they don't even notice it. I will also add that in my transplant clinic, I'm often really surprised in a way that questions come up about things like hair growth and pigmentation. But I do believe that, transplant patients have just as many cosmetic questions as everybody else, and that there are a lot of sort of connections between medicine that is purely medical and medicine that is for cosmetics. So I am fortunate to be someone who practices both on the cancer side and also on the cosmetic side. And so in my clinic, I'm really able to often offer folks both sides of the coin. And sometimes that's pills and creams, and other times we're even doing, Botox, lasers, fillers. I think a lot of times when patients start to feel better after they get their new organ, they really feel like they have a new lease on life and they want to really enjoy every day to its fullest. And so I really support people in that journey. In fact, I think it's one of the things I love most about taking care of transplant patients is that they are so grateful for every day of life. And it's almost like, every day is truly full of joy. And we see that in the clinic. So, please, don't be afraid to bring these questions to your doctors about skin rashes and about hair thinning, because all of these things do at times, have treatments and things that we can do. So tacrolimus has two cousin drugs that also have changed the landscape a bit, sirolimus and everolimus. And these are called mTOR inhibitors. So they work on a slightly different pathway than the calcineurin inhibitors, but it's a similar downstream effect that allows transplanted organs to be left alone so they can stay healthy. But these drugs can cause a number of things that you may see on your skin. You may have plantar peeling, which just means peeling of the skin on the palms. You may see acneiform eruptions, meaning pustules and papules, typically on the trunk or on the back. You may see a lower leg ulceration or even swelling of the lower legs. Someone, by the way, we just had a question from John that says, how do you tell the difference between hair loss from genetics and hair loss from tacrolimus? So I would say that hair loss is almost always multifactorial. So hair is one of the hardiest structures on our body. And people have questions about hair loss frequently during my day. I often tell them, we can't always tease out what's from this and what's from that. Sometimes there are patterns where certain types of hair loss are more likely in the frontal scalp, but sometimes maybe you do have androgenetic alopecia, meaning hormonal hair loss on the frontal hairline, and then when you go on tacrolimus, things really escalate. Either way, usually the treatments are going to be fairly similar. And so even if you're noticing just a worsening of your hair loss on the new drugs, that's still something to ask your doctor about. because it's still appropriate to go on treatment and to do things for it if it's bothering you. And again, everything in medicine is a risk benefit ratio. And a lot of times, we focus on, well, if everything else is healthy, then yes, we can add in other medications for hair. So really good question, and great things to bring to the clinic. So as far as other things that we see in the skin because of these medications, we sometimes see infections. And you may have noticed, I would say the most common is people getting little bumps like on their lower legs or on their faces that are usually a form of a wart, like HPV, which is a virus that causes these little bumps. Generally speaking, they stay small, but not always. Sometimes they can take the form of a larger wart. You could have more plantar warts. You could even have warts on the genitalia that maybe were present years ago and then reemerge when you go on the transplanted drugs. So these are all, again, things to ask your dermatologists about. I think most transplant doctors probably are mostly focused on, your organ health, but they always have on their speed dial a good dermatologist, and we're always happy to help. So other things that you might see less likely, but still could be present, would be molluscum, which tend to be more umbilicated papules. Those also can be seen in children, just like warts can in healthy individuals. But sometimes in transplant patients, they're more extreme and more frequent. Exanthems can also happen, usually in the form of pustules from bacteria. And then you may see some of the herpes viruses coming back in the form of shingles or a herpes reinfection. And usually those are going to look like little water blisters, grouped vesicles on an erythematous base. They could be on the face, they could be on the genitals. There's a lot of locations where this might be seen. Shingles itself is often on the trunk, the chest, or back, and can be quite painful. And the other thing I'll say about zoster or shingles is that there are vaccines that prevent that. So it's important that you talk to your doctor about how you could get that vaccine. And then in transplant patients, zoster or shingles can be more extreme and lead to more prolonged pain. So it's really, really important if you start to get an outbreak of shingles that you see a doctor or even like go to an ER right away to get on antiviral treatment so that you will not develop a protracted like pain syndrome afterwards. Okay, and again, just to reinforce the concept, these infections that we're talking about are secondary to the medications that are on to ensure the health of your transplanted organ. So in the event of having, let's say, a lot of these infections or something that seems really intense, you also, if you're seeing your dermatologist or let's say in urgent care, you want to make sure that you notify your transplant team. There are instances where they feel it is crucial that that medication, maybe the tacrolimus or the prednisone, be adjusted while you are recovering from that kind of infection. And as we talked about, the warts there are caused by HPV viruses, and shingles or herpes zoster is caused by the varicella virus. But both viruses, can basically be allowed to run rampant when that immune system isn't being kept as in check. Okay, so Darren is sharing with us, I'm a little over a year out from my heart transplant. I'm not on prednisone. I do take tacrolimus. with skin cancer, is there a time frame when the risk increases, like 2 years or 5 years out, and is the same risk among the races or ethnicities? So we're going to talk more about the cancer side of things in a bit, but I will just add that tacrolimus, I would say, makes skin cancers grow at a much higher rate than prednisone. We don't see a lot of skin cancers in our transplant patients who are on or the rheumatologic patients, let's say, like people with arthritis who are just on prednisone. There's something about the tacrolimus, the sirolimus, and the everolimus that affect that side of the immune system that's more linked to cancer development. We don't see cancer development the same across races. Kind of like the question about hair loss, it's still a multifactorial situation. So it is more likely to be a problem in someone with fair skin, someone who burns easily, someone who develops blistering sunburns, and someone with already a background of lots of sun damage. Those patients are very high risk and often have to be seen 4 times a year just to keep everything in check. If a patient has very smooth skin, marked skin, like they don't have a lot of freckles or marks on the face or the arms, then patients who otherwise have pretty protected skin still need to be checked for cancer, but they don't need to be checked as often. And that risk really continues to go up the longer that you're on the tacrolimus. So just to wrap up with the infection side of things, the fungal infections that can be seen include things like athlete's foot, also called tinea pedis, that usually presents with a scaly, itchy rash on the bottoms of the feet, sometimes between the toes, usually in the presence of dystrophic or thickened toenails. So if you have thickened toenails and you have a new transplant, you may want to be using an antifungal cream on your feet so that you don't get this spreading to your feet. If you have cats or dogs or pets at home or others at home that have ringworm, you want to be very careful about your skin. And if you see a rash that is like a pink plaque, scaly, you want to stay on top of that right away. Because these things, again, in a normal patient could present and stay more contained. It's not a guarantee that it's going to be more severe, but it might escalate rather quickly. So I think it's with infections, if you notice changes on your skin, especially if you have a transplanted organ, so important to get in touch with your dermatologist early, and if you don't have one, to ask for a referral. So let's jump in on the skin cancer bit, because that's definitely my area of expertise, and something as both a skin cancer screener and also a skin cancer surgeon that I really see the full gamut of in my clinical practice at Hopkins. So we know that, again, there's this really kind of nuanced part of the immune system that goes around your body, basically tagging off those cancer cells that are collecting DNA damage. And when you're on those medications, that's not happening at the same rate. But again, it is to keep that organ healthy. So skin cancer is the most common malignancy after transplant. And compared to the general population, cancer is 2 times more likely in transplant recipients, but non-melanoma skin cancer is 13 times more likely. So in the general population, 1 in 5 70-year-olds will develop a skin cancer. 50% of white transplant patients will develop skin cancer. 1 to 6% of non-white transplant patients will develop skin cancer. So again, not 0, but a little bit lower. And like we said earlier, patients who are non-white with transplanted organs are less likely to have frequent dermatologic exams, are less likely to have skin cancer counseling. And so sometimes their skin cancers are more aggressive because they've gone unchecked, unbiopsied, and unprotected for longer. So, I always make sure that all of my transplant patients get counseling, to wear sunscreen, to avoid burns, to wear protective headgear and sunglasses and clothing, because skin cancers are more likely in sun protected areas. The other thing that you might not know is that skin cancers can also develop from viruses. So a lot of times on the protected trunk, near the genital area, the buttocks, the thighs, you can see squamous cells that are perhaps HPV driven rather than driven by UV. And so those two can happen in patients of all skin colors. And with that in mind, again, it's really important that when you go in for those skin exams, that you don't just show the one spot. You really do want to get into a gown and let the dermatologist examine you head to toe. It might not seem like a scientific or, a highly evolved exam, right? They're looking with their eyes. We use our derm lights, but our eyes have been trained on thousands and thousands of images. We're like super advanced AI machines when we're looking at your skin. And so we not only have, the history of looking at skin, but we have this history of also biopsying many lesions and seeing what those turn out to be. And so, it's really important that that when you see that dermatologist, you let them look you over head to toe. Let them look through your hair. Let them look at the buttock area. Let them look through, between the toes. So take your socks off. And, it may not be a long exam. If it's quick and easy, that's great. That means you don't have anything, and you can worry about other things. But having that screening is not something to skip. And then also being vigilant yourself is the way to keep these problems small. Some skin cancers may be obvious, and you'll say, I definitely need to see a physician. If you have a black changing mole that has multiple of the ABCDE criteria, so that's asymmetry, border irregularity, color variation, or diameter bigger than the head of a pencil eraser, like this second photo here on the left, that's going to be something you're going to come in right away for. Or maybe you have a bleeding ulcer, like this photo on the right, that is a basal cell, or a large, squamous cell on the forehead. But you may just have a tiny little new papule that's a couple millimeters in size. But, usually pain, itch, bleeding, changing are your main symptoms and reason to reach out. Because, they can just be these little spots. It could be a little atrophic papule. It could be one of these brown to pink spots. And, I always like to say it's kind of like when you go to the dentist and your dental provider says, oh, you've got, this little spot that showed up on an x-ray. And you're like, I don't think I have a cavity. Like, what are you talking about? We often find skin cancers that look so small, but under the skin, they're much larger. And so catching them when they're early means that you're less likely to have a larger surgery or a larger repair. And so doing those regular exams is really important. How regular, I think, really depends on your skin type. I have transplant patients that see me every three months. I have transplant patients that see me once a year, and I have transplant patients that see me every 2 or 3 years. If they truly have nothing and we're dealing with a situation where they maybe have other doctors they need to see more frequently, but we definitely want to at least be available for spots of concern. And that's why it's really important that every transplant patient gets a baseline exam, ideally before the transplant, but if not, then within that first year of having the new organ. So what we know about these non-melanoma skin cancers are that they occur on average 30 years earlier than in other patients. The names of these tumors include basal cell and squamous cell, and patients may have frequent and multiple skin cancers with a more rapid rate of growth, an increased rate of recurrence, and increased rate of metastasis. I see that we have a question here. Okay. So, would you recommend that transplant patients specifically see a transplant dermatologist versus just a regular dermatologist? So, I would say I think it is just fine to see any dermatologist as long as they're board certified. You want to make sure that you're seeing someone who has credentialing and training in skin exams. But most dermatologists are well aware that the transplanted patients have a higher risk, and I think it's really important that, again, that you're just following up regularly, and it's someone that you trust. You establish that relationship, and really seeing that same person regularly is so powerful. And then Heather says, I had a desmoplastic melanoma that my dermatologist didn't recognize for 2 years and didn't think it was anything. They started to change and I asked to be removed. He did and was this type of melanoma. Patients should be diligent. And I couldn't agree more. Melanomas do not always look clearly problematic, nor do basal and squamous cells. I always say, to my transplant patients, but also to all my patients, ultimately I trust you. If something is changing, if something's bothering you, let's biopsy it. Let's get that peace of mind. But even more so in a transplant patient where the risks are so much higher. And if something is new, a new spot, you really should get it checked out. Doesn't mean you need a biopsy, but it does mean that you should have someone look at it. Someone also brought up mycophenolate. So mycophenolate mofetil is another medication that a lot of my transplant patients are on. I would say that mycophenolate is very similar to the tacrolimus. It affects a similar part of the immune system. And so it also does increase the risk of skin cancer, perhaps not quite as high as the tacrolimus, but it does really increase the risk of infections and all of these things. So I would say it's sort of in between prednisone and tacrolimus. So who is most at risk? I would say that definitely my older patients who have acquired more UV damage are my highest risk folks. So, 60, 70, 80-year-olds, but it's not uncommon that a 40-year-old may have, a transplant patient may have to have something removed. And then the longer from the transplant and the higher levels of immunosuppression do mean a higher risk. So when your transplant doctor, let's say, increases your tacrolimus because maybe your kidney isn't healthy or your liver isn't healthy, that is going to raise your risks. And so you probably need to also escalate your risk prevention strategies for skin cancer. So squamous cell, again, one of the two major non-melanoma skin cancer types. These are usually found in highly sun-exposed areas, but can also be virusly caused in protected areas. They can form from actinic keratoses, which are these gritty papules usually found on hands, temples. I always say those are things that we often pick up with tactile sensation, even more than what we see. And so that's why your dermatologist may want to freeze and may want to put you on chemotherapy creams to help clear up that background damage. 5-FU is an example of that, or imiquimod. It's important to know that squamous cells are 65 to 250 times more likely commonly seen in transplant recipients than in other patients. So The squamous cells are much more likely to be seen than basal cells, about 4-to-1. And then if you look at the rates of these cancers in transplant recipients, again, it far exceeds what we see in the general population. Basal cell is 10 times more likely in transplant recipients and often is formed by a pearly papule, or what we call the rodent ulcer, meaning it's kind of a bleeding, crusted, raised papule seen in sun-exposed areas that just won't heal. Melanoma, as I described, is this irregular brown spot, the ABCDE criteria with a changing mole. And this is 4 times more likely in transplant recipients. Melanoma is usually seen on the back of the legs or the back. And again, similar patterns to what we see in the general population. So how do we prevent skin cancer? Well, there's lots of things that we can do, because we do know that these UV rays, UVA and UVB, are causing skin cancer, along with usually a genetic propensity. So if mom and dad had skin cancers, you're more likely. If you had lots of blistering sunburns before the age of 18, you're more likely. If you played a lot of sports, if you had a job where you worked outside or still do, post carriers, pilots, people that, work in landscaping or work as a coach, or, any job where you're really outside a lot, these are known risk factors, not just in transplant patients, but in everybody. We know there's lots of types of UV, but as a quick sort of, refresher on this, the UVA are the deeper rays that can pass through windows in your car and office, and these form aging and wrinkles. Whereas UVB are the shorter rays, so sometimes screened out by windows, but these cause sunburns and they also cause most skin cancers. That being said, wearing sunscreen every day, at least to the face and maybe the hands, I think is a great practice 365 days a year. Really, if you have the opportunity to even prevent these skin cancers, even better. So before the transplant, go in and get a skin exam. Talk to your doctors about your risk. Go in and see a dermatologist. Have a strategy, have a plan. Go get that regular skin exam. And examine your own skin monthly, as one of our listeners already shared with the group. Sometimes you all are going to be the squeaky wheel that picks up on something not being right. And then also, your dermatologist is more likely to find something that is thinner and smaller than you are, just like a dentist picking up on an early cavity. So if they pick up on these little precancers, don't be afraid to have them do a little freezing, or, have them give you some chemo cream to put on, let's say, the forehead or the cheeks. An ounce of prevention is worth a pound of cure. And it gets so much more complicated when we're doing frequent surgeries and, frequent Mohs procedures. Even though I am a surgeon and I do those procedures, when I'm in there doing exams and doing preventative care, I always say, this is to keep you out of the surgeon's chair. Unfortunately, some of our transplant patients go through so much skin cancer surgery that they really get truly kind of beaten down by the process. We almost call it like surgical fatigue. And we don't want to get to that point. We want to be in the driver's seat, preventing these things from occurring. And really along those lines, I always share with my patients that this is a marathon, not a sprint. So let's say you go into the office and your dermatologist finds a small precancer or maybe an early skin cancer. We don't always have to freeze or to biopsy that the day that you're there. But, if you continue to sort of kick the can down the road, eventually you will get kind of behind the 8 ball. And then oftentimes you're sort of paying for lost time. So instead, have a strategy, work with your dermatologist, we all want you to have very full lives. We want you to attend weddings. We want you to go to graduation parties and go out to dinner and go on trips and go on vacations. And in fact, hearing about those things from my patients really is one of the best parts of my job. I promise you, we're not trying to torture you with these treatments, but really, don't be afraid to ask the right questions. And again, like making sure that you are coming in for those check-ins. It's a lot like how you would maintain a car, right? Like when you get those oil changes regularly, you're good for another 10,000 miles. And I always say, like, we got to get you good for another 10,000 miles. See, we had another question here in the chat. Is there a minimum SPF level that you'd recommend? So, SPF, I would say, is at least 30, if not something more like 40 or 50. You want to really be using broad spectrum sunscreen, and you want to be reapplying it every 2 hours, if you're going to be out in the bright, bright sun. I put on like a physical sunblock every morning. I'm not a transplant patient, but just to prevent skin cancer and wrinkles. It doesn't have to be a lot, but I think a lot of times people don't even realize how much sun they're getting walking to and from their cars, walking in and out of buildings, maybe taking that walk over lunch with a coworker or going out and getting lunch with a friend and you want to sit outside. Like, it just makes sense to almost make it part of the routine first thing in the morning. I always tell my patients, like, put it on first thing with your deodorant. Like, you brush your teeth, you put on deodorant, you get your sunscreen. And that's really the best way to be able to have that prevention right from the get-go. Okay. All right, so like we talked about, we want to do this aggressive sun protection. So find something you like. There's lots of brands that are great, and I do feel like the sunscreens available now are so much better. Remember that UVB peaks from 10 a.m. to 2 p.m. If you have a smartwatch, I always look in the morning, what's the UV index going to be? UV indices range typically up to 10 or 12, depending on which range you're using. So when you're getting up in the 4, 5, 6, 7 range and higher, you really do have to be careful. Looks like we have another question. I do think that sun protection clothing is effective. I'm a very big fan of it. And I do like the polypotamus leukotomas sunscreen pills. I'm going to talk about that in a minute. I love this tip as well. Sunscreen that comes in stick form can be carried in a pocket or purse. Facial moisturizer with sunscreen is easy to find. Lip balm with sunscreen. And sometimes you even can get free sample sunscreens and free lip balm at all kinds of county fairs. I tell my kids about this too. Like, my kids are not big fans of sunscreen, but I also carry those little sticks around. And, that way, if it's last minute, it's like, okay, run it down the nose, get the malar cheeks, get the forehead, run it along the tips of the hands and the forearms. All of those areas where we know the sun is going to have its highest effect. What about applying multiple things on the face? So for that, sunscreen should be applied ideally 15 minutes separately from other products. So, it's up to you whether you want to put that on first or whether you want to put that on after. But I would say, like, for myself, I usually put on like a facial serum in the morning, and then I just use like a tinted sunscreen as my makeup. And then sometimes if I want to put on a little moisturizer on top of that, Again, I just try to wait 15 minutes. You could, though, do the moisturizer first, wait 15 minutes, and then do the sunscreen. Most people really under apply. So as we're going into this, this sunny season, this is like a perfect time to have this talk, because we're going into such a high yield time to start incorporating new sun safe habits. So, don't be afraid to put on, at least like a pea-sized amount for the face. If you're covering other body surfaces, you might want to have multiple formulations, creams, sticks, those sorts of things. So a sunscreen's going to show you what the SPF is, that it's broad spectrum, if it's water resistant, and then also what the active ingredients are. So, we've talked about some of these things, but you might look for things that have some of these seals, like from the Skin Cancer Foundation. It'll show you the difference between a daily use and an active seal. The daily use is something that would be great as a base layer, and the active seal would be something if you're going to be out at the beach, out at a soccer game, something to wear at the beach. I really think, honestly, though, the best thing to do is to get some of these and just start to experiment, because we're all different. We all have different lifestyles, different needs. We do different activities, and you may live in a different climate. I've had to change my skin routine, the various places that I've lived: Boston, Nashville, Iowa, now Maryland. And you have to sort of, I think, read the environment as to how much heavy stuff you want to have on your face, or it may cause breakouts. So I think, summers in Maryland, you want to be looking for those lighter sunscreens for your face that are not going to clog pores, that are not going to leave residue. And, again, if you ever reach out to me and want some specific names of things, I can provide that to you as well. In terms of active ingredients, I think this is a really important thing to know. So there are chemical and physical sunscreens. Chemical sunscreens are the sunscreens that basically engage with the UV light in a chemical reaction. Once that reaction has taken place, the chemical is kind of kaput. Whereas a physical sunscreen is tiny little pieces of metal that are cut up. It's zinc and titanium, and they form like little mirrors on your face, just reflecting back the light all day until that product is, has been sweat off. I personally use a physical sunscreen every day for a couple of reasons. That is what is recommended for, let's say, children, and from a safety standpoint, those physical sunblocks tend to last longer in the day, and they tend to be less irritating, because for some of us with sensitive skin, when the chemical reactions take place with the chemical sunscreens, those can then create irritation and redness. That's not to say that they're all bad. It's not to say that you won't like a chemical sunscreen, because they are often lighter on the skin. And a lot of sunscreens will have both, right? So there's some that are just chemical, some that are both, and then there are some that will be labeled physical or mineral. Those words are exchangeable. You may also see something labeled for children or for babies, and that will also be a physical or a mineral-based sunscreen. So again, the physical blocks are longer lasting, less irritating, and the chemical sunscreens are often lighter. And this shows some of those things that I've talked about. So if you look at the FDA approved sunscreen agents, you can see that titanium dioxide and zinc oxide are those physical blocks. And then the long list of chemicals below that are the ones that, again, also provide more protection, but may cause irritation. So we want you guys finding something that works, that you'll actually use. Be honest with yourself. it can't help you if you're not wearing it. So again, if you're looking and you're asking questions about safety, the zinc oxide and titanium dioxide are the only ones that have this GRASE status, which is generally recognized as safe and effective. So if you have any questions, if that's something that worries you, I think, that both are acceptable, but for different reasons and for different patients, one may be better than the other. This also, I think, provides a nice list of some that are favorites of our patients. Sunscreen even comes in tinted forms in a compact. So, I actually sometimes carry that around, and if I need, some extra coverage, you can, cover up your eye bags and wrinkles at the same time that you're giving yourself a little sun protection. So we love a good 2-for-1. And remember, too, that that's preventing wrinkles. So it's so good for you across the board. And I promise you, wearing sunscreen on your face every day is not going to negatively impact your health or your vitamin D status. We get so much vitamin D from food. I can tell you from my own and other patients' experiences that plenty of us have healthy vitamin D levels wearing sunscreen every day. It's about everything in this world of health really is about balance. And we certainly don't want you getting more UV on the face just to get vitamin D and then ending up with multiple scars and marks on the skin because you've had lots of cancers. Sunscreens do expire, so remember that you want to protect with effective sunscreens. One good indication if you can't find the label or the date is just to look at what the product looks like. If it's separated at all, that's a good indication to set it aside. And then this is something that was asked about earlier. So Polypodium leucotomus. This is an extract that's a natural antioxidant derived from Central and South America. It's found in Peru and other countries there. And actually, some of the populations there were found to be chewing these leaves. And there was a Harvard dermatologist, Dr. Fitzpatrick, who actually studied this in patients, looking to see what it did to then their experience with UV light. And what they found is that chewing the leaves or taking this extract resulted in the patients having needing a higher dose to get redness on the skin. So a higher dose of UV to then develop sunburn. And because of that, it has been compounded and sold commercially. And there now are a few brands. So I'm not promoting one brand or the other, but just to say that, these pills and these gummies that are available are a game changer. I would say this is not something that I recommend to patients daily because we don't necessarily have long-term safety data, but I do think it's something to employ on a day when you know you're having high sun. So this is the thing to take to the beach, or let's say you're watching kids or grandkids play soccer all day on a Saturday, and it's going to be very sunny. You take it 1 to 2 hours before you're going to be outside. Yes, it's still smart to wear regular sunscreen, but the two work together. And I do this with my kids. I'll hand out the pills or the sun gummies when we go to the beach. And that way, it's just helping everyone to avoid sunburn. Sun protective clothing is another strategy. Sunglasses even are part of sun protection. So, and also remember that these things are economical. You can use these for multiple seasons. So a lot of people really like these as an approach. So be safe in the sun, avoid peak hours, 10 to 2, or reapply your sunscreen, especially every 2 hours during those periods. Think about sun protective clothing, hats, shade structures, and sunglasses. And then remember to find a sunscreen you'll actually use, SPF 30 plus, broad spectrum, and water resistant. And then how do you do a skin exam? Well, you look at yourself head to toe, check each area methodically. Don't forget things like underarms, looking at your legs, looking between the soles of your feet and toes. A mirror can help you examine the neck and scalp, and it may even help with harder to reach areas like the genitals. But anything that you're not comfortable with or anything that is difficult to look at, it's fine to also leave that in our hands, provided that you're seeing us regularly. So no one should die from a preventable skin cancer. You know, you are in the driver's seat here, and what you do does matter. So use your sun protection, do your self skin exams, and make sure that you also, go see your dermatologic providers. I just want to throw a little thanks here to those who really paved the way: Dr. Loss, Dr. Bybee, and Dr. Stump, who have been part of this transplant clinic before. Dr. Evan Lipson runs our skin cancer program from the oncology side, and he and I collaborate a lot. And Magdi Algnanim is my student and fellow who's worked with me this year, providing also a lot of great support to these patients. So with that, I will thank you all for your attention. You guys have asked awesome questions, and I hope you guys have a beautiful summer protecting your skin.
Dr. Powers, this was awesome. I think it was so thorough. I mean, most of us have heard some of this before, but I think you presented it in such a way that helped us get from the beginning to the end and understand why all of this is important and why we need to be vigilant. And especially if your husband has had more than a couple Mohs surgery, you know how
Oh yeah.
important.
Oh yeah. If you see one of those, you realize that you do not want to end up in the surgeon's chair too often.
Exactly.
One is enough. Once is enough.
Exactly. And one person did ask, how often do you reapply tinted face moisturizer?
So that's a good question. I'm guessing like tinted sunscreen, maybe. So I would say, like if you're just having a regular
Mhm.
inside day, I put it on in the morning if I'm going to work. And if I'm not going to be out in the sun again, I think as long as you haven't sweated off or you haven't been in an environment where it's going to disappear, and you're not sitting out on the beach, then you may not need to reapply. If you go out at noon and you're going to be in the bright, bright sun for an hour, then you should probably put a little bit more on or throw a hat on top. But I will tell you, I do think that the first thing in the morning is so critical because it's so hard. Life gets so busy. And, we just want to be out there enjoying ourselves. Like, oh, a friend asked to go for a walk. Great. Like, do you want to be fumbling in your car before that? No, you want to like prepare for the day. But I will say keeping like a stick of sunscreen in the car, which is what I do for my kids and myself. I keep one in every car. I try to keep it accessible so that if you forget or you do need that reapplication, then you've got it handy. Anytime you're outside, you need to reapply every 2 hours. And I use my smartwatch when I'm at the beach with my kids to reset a timer. And that way I know, like, okay, time to, do the sunscreen rounds again so that nobody gets burned.
I just a couple other comments. Kelly, let everyone know, don't forget the tips of your ears and the part in
Yes.
your hair. Because
Yes.
she did when they were in Puerto Rico and she kind of suffered from it.
Yeah.
You have like just thousands of thank yous and wonderful presentation, excellent information. And Darren said he appreciated the recommendation about checking the expiration date because he needs to go buy more
Yes.
sunblock because his is expiring. So
Mary Ann also raised a good point about the red light therapy. So, absolutely right. Like, prevention is multifactorial, and treating the pre's ranges everything from freezes to the chemo creams to something called PDT. And photodynamic therapy, unfortunately, is not offered at all clinics because you have to have a special blue light, but you are painted with this little stick of medicine that makes the precancers get activated after about an hour of absorption. And then you sit in this blue light for like 16 minutes, and it does sting a little bit. Like you get a red kind of sunburn like glow afterwards, but that is great because it's in office. Whereas the chemo cream is sometimes like 2 weeks, and it's a tough one for people to do.
Again, excellent. Thank you. Thank you. Nice meeting you.
Yeah.
And don't forget, Dr. Powers is at Hopkins. If you're looking for a transplant dermatologist or you're thinking of changing, Dr. Powers is there at Hopkins.
And we want to thank everyone for attending today. We love seeing your smiling faces on a Saturday morning. Don't forget to check out our events page on our website for advance notices of future meetings. And our website is www.triomaryland.org. All of our past meetings are posted to our YouTube channel for your viewing convenience. Have a great weekend, guys.